I haven't heard the word. Ladies and gentlemen, good morning. And this is good morning from the UAE. It will be good afternoon for our speaker, Dr. Ravi Andrews, who is speaking to us from the prestigious Apollo Hospitals, Hyderabad in India. Now, this series of webinars, which we call the DiaBeat series, is part of our larger program, which is beating diabetes through lifestyle and medicine. We've had about 6 or 7 webinars till date. We divide our webinars into 2 categories: the health aspects, in which we've spoken about nutrition. We had another seminar on diet. We had last week a webinar on lifestyle management. And then we have the series on medicine, in which we've had the clinical aspects of diabetes. A few weeks earlier, we had retinopathy, and now we have nephropathy. Whatever I have read about diabetic nephropathy was terrifying, terrifying. Words like renal failure, dialysis, kidney transplant sprang out at me from the
He is muted.
Prof, you are muted. You are on mute.
Speaking too much? Okay. Now, diabetic nephropathy or kidney disease is caused by diabetes, which also increases hypertension, causes cardiac ailments, and results in end-stage renal disease. Now, these are fatal situations. Hopefully, to assuage our fears, we have an eminent speaker and a dear friend, Dr. Ravi Andrews. Can we have Dr. Ravi's profile on screen, please? Here we have it. Now, Dr. Ravi has over 30 years of medical experience. He completed his MBBS from the prestigious CMC Vellore. He then went on to do his DNB General Medicine from the Hinduja National Hospital in Mumbai, and ended with a DNB in nephrology from, again, the prestigious Apollo Hospitals. He has worked in several institutions in several states of India, Mumbai, Hyderabad, Orissa, et al. He is amongst the top rated nephrologists in India with a score of 4.4 on 5, and is only one of 3 nephrologists in India to perform a successful 3rd renal transplant on the same patient. This was in 2012. Also, the first nephrologist in Andhra Pradesh and Telangana to perform the swap kidney transplant. Dr. Ravi Andrews has several papers to his publications to his credit, the names of which I can barely pronounce. Ciprofloxacin, I don't know whether I've said that right, resistant typhoid, percutaneous transluminal renal angioplasty, God Almighty, these are difficult words. And then percutaneous transhepatic vein permcat, is that it? Well, these are Dr. Ravi Andrews' specialities. But that is not all. Dr. Ravi is an all-round personality. He is an active musician, a theater actor, a collegiate sportsman, and he still remains a fitness enthusiast. And if I'm any judge, I can clearly tell you that he is the fittest doctor. He is the fittest physical fitness professional and doctor in the Apollo hospitals. And I may add, perhaps in the whole of India. To add to that, he is an avid academic. He is a patient's doctor, and he speaks several languages: English, Hindi, Telugu, Uriya, Marathi, Tamil, Gujarati, French. And my request to Dr. Ravi is to kindly speak to us in English. Dr. Ravi, it's all yours.
Thank you very much, Professor Kennedy. Can you all hear me?
Yes.
Yes,
Okay,
Doctor.
so that was a wonderful introduction. I have a hard act to follow now after all the introduction that you've given me. So yes, welcome everybody to this program and this RAK diabetic challenge. And I really wonder who thought of this name. It's such an inventive name, DiaBeat. Yeah, I never would have thought of that. So yeah, that's a wonderful initiative that RAK Hospital is doing. And it's my honor and pleasure to join you today and talk to you about diabetes and renal health. Could we share my screen, please? I mean, my presentation. Yes, here we go. Can we have the next one? Can we move on to the next slide, please? Okay, give me a minute. Let me see if I can share it myself. Okay, so here we are. This program in RAK Hospital is going on for the last 3 months. And we can see on this particular slide why diabetes and renal health is so important and why we need 3 months to go through this, because every little bit helps. And this disease is a major one and we need to really attack it at all levels. Over 500 million people all over the world have diabetes. That's 10.5% of the world. And over 800 million have got kidney disease. That's 16%, 1 in 6. So if you're in a room with 6 people, one of them will have kidney disease. And the commonest cause of kidney disease is diabetes. 40% of kidney disease is caused by diabetes. Among the other 60%, there is hypertension or high blood pressure, medications, infections, stone disease, and a few genetic diseases. But the major chunk of the cause of kidney disease is diabetes. And as human beings, we're all worried about what is going to kill us. I'll be very blank here, very blunt here. We're all worried about how long we're going to live and what could possibly kill us at an earlier stage. And kidney disease is among the 10 top causes of death all over the world. And diabetes is there in that list as well. So diabetes and kidney disease together is a lethal combination. There are other causes of death which are in those top 10, like ischemic heart disease or cardiac strokes, brain strokes, infections, lung infections, and other things. But diabetes and kidney disease are there in that top 10. And we can put this into perspective by knowing that statistically, a 20-year-old person with kidney disease is 100 times more likely to die than a healthy 80-year-old. So kidney disease is a killer. Not only that, since we've already discussed that diabetes is the commonest cause of kidney disease, what percentage of diabetics could likely get diabetic kidney disease? 30% of type 1 diabetics and 10 to 40% of type 2 diabetics. Now we know diabetes, there are two types, type 1 and type 2. I'll quickly tell you the differentiation. The major differentiation is type 1 diabetes are basically those who require insulin, and this starts at an earlier age group. Whereas type 2 diabetics usually don't require insulin at the earlier stages, and later on they might require, but initially they can be managed with medications alone. And these usually start after the age of 40. So young diabetics who require insulin are type 1, and 30% of them are likely to get diabetic kidney disease, whereas older diabetics who do not require insulin, even a higher percentage of them are likely to get diabetic kidney disease. Next one, please.
Doc, you are sharing.
Yeah, sorry. Okay, so that switched somewhere along the way. So now this is a pretty busy slide, but I'll try and run through it quickly. We all understand the natural history of diabetic nephropathy. Now, diabetic nephropathy I'm using as a synonym for diabetic kidney disease. Diabetic nephropathy is the medical way of calling it, but for a layman, it's diabetic kidney disease. And there are basically 5 stages of this, and this is based upon the time of onset of diabetes. Now, unfortunately, in type 2 diabetics, we do not know the time of onset, whereas in type 1 diabetes, it's very clear what the time of onset of diabetes is, and we can try and extrapolate the natural history from type 1 to type 2 as well. So by natural history, I mean when somebody has got diabetes and you just watch them without doing any intervention at all, either medically or from a diet perspective or from a wellness perspective, if you do not do any intervention, what happens to them? How does the disease progress? So in stage 1, that will be at onset. There is just increased blood flow through the kidneys because of the high blood sugars. And this is the reason why diabetics pass more urine, because there's more blood going through the kidneys, there's more filtration and more urine output. And this is initially increased at the stage of onset in stage 1, and there's no other symptoms here. Stage 2 is even worse. Stage 2 comes after within 5 years of diabetes, and here this is called typically a silent stage, where there are absolutely no symptoms at all. Even this increased urine output becomes normal. So this is a dangerous phase because nobody knows that they have the problem and nobody can diagnose it or treat it, because unless you do the investigations, you will not find out what's going on. And since it's silent, it will naturally slowly be progressing inside your body and your system and causing the destruction and the damage. Stage 3 is a stage of what we call microalbuminuria. And here is when the urine starts showing signs of diabetic kidney disease. This happens in about 15 years of the onset. And here there is minor loss, very, very, very minuscule losses of protein in the urine. That's why it's called microalbuminuria. You need a microscopic test to figure this out. And this range is supposed to be 30 to 300 milligram per day. This stage or the stage of microalbuminuria is the crucial stage. This is the most important stage, because if you can find it out at this point in time, with treatment, you can prevent diabetic kidney disease. So this is the crucial stage, and the only way to figure this out is to do a urine test and look for urine microalbumin. The next one is stage 4. Once we've crossed stage 3, this is a stage of overt nephropathy, or when there is overt kidney disease, where there is protein loss significantly in the urine and the patient starts getting high blood pressure and they start getting swelling. So this is stage 4, and at this stage, we cannot reverse the problem. So you have got established diabetic kidney disease here, but there is a light at the end of the tunnel. At this stage, you can slow down the progression. You cannot arrest, you cannot reverse, but you can slow down the progression and you can prevent the person from going into kidney failure. And the final stage is stage 5, where the creatinine starts increasing, the blood pressure starts increasing, and soon this patient will be on dialysis. Now we're talking about this is, don't take this negatively. This is the natural progression. This is how it progresses over the years without treatment. If you can pick it up early and start treatment, this natural progression changes and you can drag things out for a much longer time. And sometimes, like I said, if you get it at stage 3, you can even reverse the problem. The caveat here, like I said, stage 5 would be after 25 to 30 years of diabetes. The caveat here is if you don't get diabetic kidney disease after 25 years, you are unlikely to get it. You are protected. So if after 25 years of diabetes, you kept your sugars well controlled, no evidence of diabetic kidney disease, you are not going to get diabetic kidney disease ever. But that doesn't mean you have to take it light and take it easy and just go haywire. It still means that you need to keep your blood sugars and your blood pressures under control. You need to make sure that the lifestyle modifications that you're doing are in place. Now, any disease, the thrust of modern medicine is prevention rather than cure. And we all know that we all want to prevent things from happening rather than doing damage control or damage limitation. It will be interesting to all of you to know that the prevention of any disease, forget diabetic kidney disease, the prevention of any disease has got 5 different levels. It's not just about identifying early and treating it. So I will spend a little time on this slide because this is important for us to know and to know the different levels at which we can prevent a clinical condition or a clinical disease. The first is a primordial level of prevention. Now, remember, we're talking about diabetic kidney disease. I'm going to specifically talk about diabetic kidney disease here. Diabetes is the cause or the risk factor of diabetic kidney disease. So if you can prevent diabetes itself, and I think that's what this RAK DiaBeat challenge is all about. If you can prevent diabetes itself, you're obviously automatically going to prevent diabetic kidney disease. So that's what the focus of our community should be, to prevent diabetes itself. And how do we do that? Health education. You need to educate the general public, you need to educate the physicians, and so they need to understand what are the early signs and symptoms of diabetes, what are the methods you can prevent it. So educate people, ensure everybody after the age of 18 gets a blood sugar test. All of us mostly at some point in time, we get a BP checked, we might get a hemoglobin checked. We should also do a blood sugar check at some point in time, and if possible, even a serum creatinine. But we'll come to that other levels of prevention later. Let's first focus on the primordial or the initial method of prevention of diabetes. So health education, surveillance, go through all people, young adults, especially those who've got family history of diabetes or family members who've got diabetes, do surveillance, ask them whether they have increased the typical symptoms of diabetes, high urine output, more thirst, more hunger, and frequent infections. So surveil them, check blood sugars at intervals at least once a year. If you're at risk, if you're not at risk, at least once in 2 to 3 years. And this should start at a younger age. And also health promotion. And I'm sure Dr. Kennedy will agree with me here, health promotion. So lifestyle modifications, exercise, diet, this should start at a younger age itself, and specifically those who got risk factors for diabetes from their family members or who are obese or whatever. These people need health promotion, and they need to make sure that they do whatever they can do to prevent diabetes itself. Moving on to primary prevention. You've already got a risk factor. The risk factor for diabetic kidney disease is diabetes. Now, you did whatever you could in the primordial level to try and prevent diabetes. It didn't work. You developed diabetes. So that's one risk factor you have for diabetic kidney disease. What would you do then to prevent the onset of diabetic kidney disease? Tight blood sugar control. And we all know about this. We need the targets that everybody talks about, most physicians talk about, is to keep your blood sugar below, your fasting blood sugar below 120 milligram per deciliter, your postprandial below 160, and your glycosylated hemoglobin below 7%. Now, the WHO says the definition of diabetes is if the fasting blood sugar is more than 126 or the post meal is more than 180, or sorry, more than 200. But if you want to prevent diabetic kidney disease and you have diabetes, you have to keep very tight control. This might theoretically be possible, but practically difficult to achieve. But that should not prevent us from trying to get these targets. So Once you get diabetes, keep your fasting below 120, post-meal below 160, and HbA1c below 7%. The other thing that you need to do, because diabetes and blood pressure go together very often, is to keep tight blood pressure control. The target recommended BP is to keep it below 130/80, and which blood pressure medicine you're going to use will depend on your physician, and there are certain reasons to decide and choose one particular medicine over the other. But the target BP for younger people especially is below 130/80. But if you're slightly elderly, you can have a slightly looser target and keep them around 140 to 140/90. Apart from these two things, lifestyle changes are very important. Diet, exercise, your behavioral pattern, make sure that you have a positive attitude, you sleep well, reduce alcohol, stop smoking, and lead as far as possible a healthy lifestyle. And I'm going to talk a little bit about diet and exercise later on in these slides, but this is just roughly, these are the changes you need to make. Weight control is crucial. And what investigations would you like to do to identify diabetic kidney disease early? Would be to do basic tests, which can be done at any lab, serum creatinine, serum electrolytes, urine examination, urine albumin, and these need to be done every single year. The next level of prevention is secondary prevention. Once you've not been able to prevent diabetes, so the risk factor is out, you got diabetic kidney disease, how do you minimize the damage, and how do you minimize the complications, or how do you prevent the complications? That is the secondary level of prevention. And the main complications, as I think most of us know, are brain strokes, heart attacks, infections, blood clots causing gangrene, diabetic kidney disease, nerve damage, neuropathies, and eye damage, which is labeled retinopathy. The important thing here is early diagnosis, and the early diagnosis is based on the symptom, signs, and labs. So symptoms and signs, let me dwell a little bit on it, because the physicians, I'm sure, would be aware of this, but the non-physicians, the non-medical people, you need to have some handle and to decide when you need to see the physician or your doctor. So the symptoms, the easy way to go about it is to go from head to toe. So in the head, you will feel tired, weak. This I'm talking about somebody who's getting impending diabetic, who's got diabetic kidney disease, and complications are setting in. So you will feel tired, you will feel weak, you will your memory you might have a little bit of memory losses. Going down towards the eyes, there will be pallor. That means there is signs of anemia. There could be diabetic eye changes, so there could be blurring of vision or visual losses. Going further down to the mouth, there's a change in the sense of taste. So your things don't taste as they normally would. There'll be a difference there. Your appetite might go down. Going down towards the chest cavity, might have difficulty in swallowing. Some people have breathlessness. Over the face, you could have swelling as well. This is because of retention of fluid and losses of protein in the urine. Abdomen, you might have some bloating, discomfort. Some people have constipation. Some people have diarrhea. In the bladder region, you might have difficulty passing urine. The urine output can increase or decrease. And below that, the legs, you can have swelling of your feet, or you can have cramps and pains. So just to put this into a nutshell, quickly, the signs and symptoms of impending diabetic kidney disease: swelling of the face, appearance of anemia, losses of appetite, changes in urine output. So it could be more urine output than normal, or even could be less. The general misconception is if you have kidney disease, you should have less urine output, but that's not necessarily so. Sometimes even more urine output can also be a harbinger of kidney disease. And then finally, swelling of the feet as well would be an indicator that you're getting diabetic kidney disease, and you need further evaluation. And what further evaluation do you need? You need lab tests, serum creatinine, simple basic lab tests which can be done anywhere. A creatinine, a complete urine examination, urine albumin to see whether there is protein in the urine, and in some situations an ultrasound of the abdomen, just to make sure there is no other problem apart from the diabetic kidney disease, whether there's some stone disease or some obstruction or anything like that. These are simple tests which can be done anywhere. Once you establish that you have diabetic kidney disease and you want to prevent the complications, you need to start treatment. And there are specific methods of treatment for diabetic kidney disease. Apart from treating the diabetes and the blood pressure with general medications, there are some newer drugs which I'm sure your physicians will be aware of. There's a drug called dapagliflozin, and it showed a lot of encouraging results nowadays. And it can reduce the complications and incidence of diabetic kidney disease or reduce the progression by up to 30 to 40%. So that is a significant percentage, positive percentage. Preferably, if you have diabetic kidney disease, you would like to use insulin. Now, there is a paradox here. When you have diabetic kidney disease and your serum creatinine values are increasing, your requirement for insulin and other oral hypoglycemic agents to reduce, anti-diabetic drugs to reduce your sugars, the requirement comes down. The reason is, one is because of kidney disease, you're not eating so much, your appetite is less, so your blood sugars stay at a lower level. Plus, whatever medicines you use to control your sugars have to be excreted to the kidney. And when the kidneys are not working as they should, this medicine is not excreted adequately, and the levels in the body stay higher, and your blood sugar levels are lower. So the paradox here is, just because your blood sugars are getting better, it doesn't mean that you are getting better. Your blood sugar control is getting better means probably that your kidney function is getting worse. So that's where, when somebody is finding out that suddenly their blood sugar levels are getting controlled in a better way, in spite of the same dose of medications, in spite of the same diet that they're taking, that means that possibly they will have to check their creatinine and ensure that their kidney function is the same or gotten worse. The other medicine that nephrologists and physicians use are certain blood pressure medicines called ACE inhibitors or ARBs. Now, these are blood pressure medicines, but its research has shown that they are useful also in reducing or slowing down the progression of kidney disease, and over and above blood pressure control. So these are the few drugs that are there in our armamentarium as physicians to control the complications of diabetic kidney disease. There is a new drug which has come into the market, which has newly been approved by the US FDA, called Renal. And this is supposed to reduce the risk of diabetic kidney disease by 40%. And not only that, it has effect on cardiovascular system, on the heart as well. So it's both ACE inhibitors, ARBs, and Renal are useful for both cardiac disease as well as kidney disease. The other thing that we need to do, which we most of the time forget, is regular follow-up. And many a time we feel better, we don't need to go see the doctor, we don't need to go to the hospital, and we just take things lightly. But regular follow-up is crucial, because most of these things are the tip of the iceberg. Most of these are under water level. You don't realize what's happening unless you do the test. So the creatinine, the urine examination, and other basic investigations need to be done on a regular basis, preferably at least once a year. But based on your creatinine value, your doctor will decide whether you need to do it once a month, once in 2 months, 3 months. But regular follow-up is absolutely crucial, so that you're on top of things and can manage things faster. The tertiary level of prevention is damage limitation, where you try and prevent disability or death. And finally, quaternary, or the last level of prevention of any disease, and also particularly diabetic kidney disease, do not take unnecessary medications like painkillers, antibiotics, and herbal medicines. Herbal medicines are a complete no-no, and painkillers, antibiotics are going to worsen your kidney disease. So do not take them unnecessarily. And if you're going to take them under the guidance of a doctor. I will quickly run, because everybody is worried about stages, or wants to know, like after cancers, we all talk about stages. There are 5 stages of chronic kidney disease, and I'll try and simplify it for you. Generally, the medical personnel talk about GFR, which is a calculated value, and there are 100 different formulae of GFR. So it's a very cumbersome method. So stage 1 GFR of 90 to 120, stage 2 60 to 89. That's not possible practically. So the easiest way and the rule of thumb that we use is a serum creatinine. And the simple thing, if stage 1 kidney disease, creatinine 1, stage 2, creatinine 2, stage 3, creatinine 3, stage 4, creatinine 4. So easy to remember. And stage 5 means a creatinine of more than 5, or somebody who requires dialysis. I will now move on to diabetic kidney disease specifically. And before we go on to the diet and what we need to do for diabetic kidney disease, I would just like to reiterate about chronic kidney disease. Now, a creatinine value alone is just enough to tell you that you have kidney disease. Whether you have chronic kidney disease or something called acute kidney disease is what time will tell you. And by definition, chronic kidney disease is a kidney disease which has been going on for at least 3 months. So if you have a creatinine of say 3 months ago, and now it is 3, this is labeled as chronic kidney disease. Whereas acute kidney disease is something which has been of recent onset and has been going on for less than 3 months. And like I give you another example, if your creatinine was 1 or it was normal about 3 months ago and now it is 5, even if it's 5, it's so much higher than 1 and so much higher than 2 or 3, but you'd still label this as acute kidney disease. And the reason I'm stressing on this is treatment. If you have acute kidney disease, there is hope that it will recover. This is crucial to know. If you have chronic kidney disease by definition does not get reversed, but you can slow it down. But you cannot stop it, you cannot reverse it. But acute kidney disease, no matter what the creatinine, even a creatinine of 10, if you can identify the cause of acute kidney disease and treat it, you can reverse it and you can get normal kidney function. This is a crucial difference. And the only thing that will tell you definitively is a previous creatinine. And that's where this option of or the concept of doing regular follow-ups and checking creatinine on a regular basis comes in. So you can think about finding out what the basic causes and try and treat it. So acute kidney disease, chronic kidney disease cannot be reversed, and just damage limitation there. Acute kidney disease can be reversed. You should make every attempt to find out the reason, and the way to differentiate between these two is the serum creatinine 3 months ago. Now, I know all of you, most of you are in Abu Dhabi. So the creatinine values that we use over here, probably they have different standards over there. So a creatinine of 1 milligram per deciliter in India, in a different unit in Abu Dhabi is probably around 88 millimoles per liter. So just keep that in mind. So, don't get shocked when you find a value of 88 and then here Dr. Ravi Andrews is saying creatinine of 1 is normal. Now let's get back to diet. Dr. Ruba, sometime back, a few weeks ago, she gave a wonderful lecture. I saw that, and she in a very detailed manner, discussed about the diet. So I will tell you this basics, what we need to do from a diabetic kidney disease perspective. And the first line there you can see is do not use herbal supplements. I mean, there's this whole army of people who say you need to try herbal supplements. People will tell you if you have kidney disease, try Ayurveda, try homeopathy, try these herbal supplements. They're harmless. No, they're not harmless. They are harmful and they do no good. Now, let's getting on now to what kind of diet is suggested in those with diabetic kidney disease. It is basically based on the different stages of kidney disease, and that's the reason why I put the stages 1, 2, 3, 4, 5. So early stage kidney disease would be stages 1 to 4. That means the creatinine till below 4, whereas the late stage will be creatinine more than 5 or somebody who is on dialysis. So the basics, you need to keep carbs at 60%, protein 30%, fats 10%. If it's early stage diabetic kidney disease, have more carbs, less protein, and the carbs that you should have are 25 to 30 kilocalories per kg per day. So for a 60 kg person, you would require 1,500 to 2,100 kilocalories. Protein restriction is essential, 0.6 grams per kg per day. You want to use polyunsaturated fatty acids, PUFA, preferably plant protein, because animal protein has a lot of uric acid and phosphorus, and that's not good for those who've got kidney disease. The ideal thing, and everybody's tom-tomming about it right now, is a Mediterranean diet, which includes nuts, fruits, veggies, legumes, very little amounts of fish, of lean meat like fish or chicken, and olive oil. And that's really good for somebody who's got early stage diabetic kidney disease. Obviously, more fruits and vegetables. Micronutrient supplements are required because most people with kidney disease have got mild nutrient deficiencies, and these would help. So the doctor will give you a particular, maybe one small little pill to increase your micronutrient levels. Calcium and vitamin D deficiencies are very common in patients who've got kidney disease. Those supplements will be required. And salt, reduce it to 6 grams of salt per day. Now remember, 6 grams of sodium chloride equals to 2.3 grams of sodium. So if you're talking about the table salt that we're talking about, take less than 6 grams per day throughout the day. So 2 gram morning, 2 gram afternoon, 2 gram in the evening. Do not add salt to the diet. Avoid hidden sources of salt like preservatives, ketchups, dairy, cheese, butter, those things which have preservatives in them, because salt is used as a preservative. Mixtures, pickles, all these things are should not be taken. Do not add salt in your diet. And the surprising thing is these products, bakery items also have a lot of salt. Even if they're sweet, they have a lot of salt because they need to be preserved. So try and avoid bakery items as well. Now there is this whole thing, the new wave about using low sodium salt, and a lot of people are using these salt supplements or these special salts which are low sodium, thinking that it will be good for their blood pressure. The problem with low sodium salt, this is actually potassium chloride instead of sodium chloride, and those with kidney disease usually have high potassium levels, and supplementing with a low sodium salt will increase their potassium levels and put them at real high risk of cardiac disease, because high potassium levels can cause sudden heart attacks or sudden stoppages in your heartbeat. So you should avoid low sodium salt. If you want to have salt, take normal salt, but less of it. Low potassium, so avoid fruit juices, avoid coconut water, avoid things like ORS and other rehydration salts, and make sure that you do not take fruits which have high potassium levels like bananas, kiwi, watermelon, and oranges. Low phosphorus, so avoid aerated drinks, especially Coke and Pepsi, and reduce red meat, because phosphorus levels are very high in kidney patients and they can cause bone disorders because of the high phosphorus levels. In the late stage diabetic kidney disease, there's not much change. Just increase the protein, because a lot of protein losses are happen during the dialysis process itself. So try and have less protein. Sorry, have more protein to supplement it. And animal protein is fine here. You don't need to use only veg protein. Now, this is something which is very close to Dr. Kennedy's heart, and exercise. This is a crucial part of management of diabetic kidney disease. And how does it help? It's all there in the list. It lowers BP, controls sugars, controls weight, improves sleep, endorphin, enkephalin. You feel so good after exercise, reduces stress, improves the cardiovascular performance, and increases your muscle strength and reduces osteoporosis. It makes you feel stronger, and your bones get much stronger after exercise. Now, talking about improved cardiovascular performance, there are so many people who say you should. There have been stories, anecdotes we hear about people going to the gym and suddenly having cardiac arrest and and dying. And people say it was exercise that did it. I don't agree with that at all, because there are some people who die at work. There are some people who die in their sleep. So does that mean that you shouldn't sleep? You might die in your sleep, so don't sleep. You might die while having exercise, or don't exercise. No, that's not the right approach at all. And these are just one of anecdotal incidences where somebody probably had some underlying cardiac disease, and then because of over exercise or not doing it the right way, they collapsed. So cardiovascular performance should be improved, and there are different methods of doing it. Not only that, about osteoporosis, people say that if you do too much exercise, you will have accelerated osteoporosis. I can tell you, for every one person who gets osteoporosis because of exercise, I can tell you 100 people who get osteoporosis because of not exercising and putting on weight and causing bone damage. So exercise is important. It reduces osteoporosis. It improves your immunity by upgrading your T cells, which help immunity, improves your posture, increases confidence. And I'm going to share what I do and how I motivate myself to do exercise in this next slide. How much do we do? How much is recommended? WHO recommends at least 150 minutes of moderate exercise per week. And the critical word here is at least. That doesn't mean you do 150 a week and you say, I'm done. No, at least 150. If you can do 200 or 250 a week, please go ahead and do it. And it should be moderate intensity. Moderate intensity means you should not be able to hold a conversation with somebody else. Most people go to the gym, they'll be on the treadmill and they'll be talking on the phone with their buddy. That's not how it works. It's not going to work. That's not moderate intensity. Or they'll go with their buddy and they'll be doing deadlifts and all that and be chatting while doing the deadlifts. No, that's not moderate intensity. So moderate intensity, you should not be able to talk with anybody. You should be, your pulse rate and your respiratory rate should be just fast enough for you to avoid talking to somebody. And that is moderate intensity. And don't target 5 days a week. If you target 5 days a week, normally in a busy schedule, you'll end up doing only 3 days or 4 days in a week. You need to target 28 days, 25 days in a month, or 300 days in a year. Or if you're really into it, 3,000 days in 10 years. Exercise is a lifelong commitment. So target 25 days in a week. There might be a week where you do 7 days in a row. That doesn't matter as long as you're doing 25 in the week. If you target 5 days a week, you'll end up doing 3 and end up doing 15 days in a month, which is not good enough. no protein supplements. Whatever protein supplements you want, take it from a natural source, and especially if you've got kidney disease. The other thing I want to talk about is music. We all know statistics and research has shown us that if you're listening to music while exercising, you can do much more. And the reason they say is because your mind is occupied. I don't think it's just that. When one of the biggest demotivating factors while doing exercise is your breathing. If you're gasping while breathing, you start feeling, yes, I'm tired, I need to stop. If you got music in your ears and it's loud and you can't hear yourself breathing, you don't think that you're so tired and you can move on, you can do more. The other thing you need to do is don't think of it as exercise. Think of it as music time. If you like listening to music, your exercise time of 1 hour, think of it as music time. If you like watching TV, think of your exercise time as TV watching time, and that would motivate you to do it on a more regular basis. So these are the tricks I use to do, and I'm sure it can be applied to everybody else. So now, just to summarize everything, because I'm sure Dr. Kennedy is itching to get on with his stuff and summarize this thing. So 10 to 40% of diabetics can get diabetic kidney disease. The early diagnosis and treatment can reverse it in the early stages. Remember, stage 3 or the stage of microalbumin can be reversed. Even in late stages, there is still hope. You can still slow it down and do damage control. Blood pressure control, blood sugar control, and weight control are crucial. Medications, diet, and exercise play a crucial major role as well, apart from blood pressure, blood sugar control, and weight control, because you can use it both ways. Medications can control blood sugar and blood pressure and weight. Diet and exercise can also play a major role in doing this. And you need a multidisciplinary approach. It's not going to be a one-man show taking care of diabetic kidney disease or any chronic disease for that matter. You need the involvement in diabetic kidney disease, nephrologist, a diabetic specialist, or an endocrinologist. You need a foot surgeon, because there are so many cases where people get foot ulcers and infections, and that needs treatment. And of course, a dietitian, a physiotherapist, and a counselor. Thank you all very, very much. And I would be happy to hand over the thing to Professor Kennedy. And I would be really happy to answer any questions that you all have. Thank you very, very much, and have a wonderful day. Keep your blood sugar, your blood pressure, and your weight under control.
Dr. Ravi, thank you so much. Now, in addition to your eminence as a medical professional dealing with renal diseases, by virtue of this particular presentation, you are nominated as President of the Lifestyle Medicine Association of India. Thank you so much for your support. Friends, I know Dr. Ravi personally. He and I have worked out in the gym together. He is extremely proficient and knowledgeable in exercise physiology, and therefore you may take whatever he says as sanctified. Dr. Ravi, I'd also like to thank you very much for your simplification of an extremely complex subject, and the amount of confidence that you have given us that we can manage the disease if we adhere to the norms that you have specified. Thank you so much for that. Now, throughout your session, I noticed that there were questions and questions and questions, and therefore we will take the liberty of holding on to you for the next few moments while Dr. Wilku has the onerous responsibility of selecting the appropriate questions from amongst the many. Dr. Wilku, over to you, sir.
Thank you, Professor. First of all, a big thank you to Dr. Ravi Andrews for a wonderful session. It was so light, easy, with all technical aspects and presented to a layman. There are many doctors in the participant also, but still, I'm talking as a layman's language. It was a wonderful session. And I was wondering, I have seen your session 15 years back. Still, the cutting edge is being sharpened more with the experience. Very good. Thank you, Dr. Ravi. Now I will take a few questions which we received in the email also and now in the chat box also. First of all, there is Munna is asking, what is best way to restrict protein in the Middle East diet? You have already mentioned Dr. Ruba has taken a session for this. They can review. And anyhow, you have already answered, but still, I would suggest you to answer for a minute.
Yeah, so Dr. Muna, yes, this is an interesting question, and there is no definite answer here because if whatever diet changes or modifications you do is based on the local case scenario. So in the Middle East, you need to make sure that whatever diet you're taking has got less animal protein in it. If you've got diabetic kidney disease, restrict it, switch directly from animal protein to plant protein. And if it's going to be animal protein, or make sure that the protein level is less than 0.6 or around 0.6 to 0.8 gram per kg per day. So it has to be tailored to the Middle East diet. How you are going to do it, what facilities are there, what kind of foods are there, I'm not really aware of it, but I'm sure Dr. Ruma would be able to help you there. So yeah, switch from animals to plants and try for the Mediterranean diet. That might do the trick for you.
I think that is the best option the patient can do. Shireen is a little concerned. She's asking, do most of the diabetic patients end up on dialysis?
Yes. So if, like I said, 30 to 40% of diabetic patients get diabetic kidney disease, but all of them do not end up on dialysis. If they are treated appropriately, probably about 10 to 20% of them will end up on dialysis. But as we saw in the natural progression, in the natural history, if you don't treat them appropriately, 30 to 40% of them are likely to end up on dialysis. And 50 to 60% of patients who are on dialysis are basically diabetic. So, Dr. Wilku, what I'm going to do is I'm going to answer the questions in short so that, we can have space for more questions. So quickly, Shireen, 10 to 20% of diabetics can end up on dialysis.
Yeah, true. Mr. Bharat is asking, he has a very wonderful question which generally we come across. It's a confusion sort of state. My brother has hypotension and he takes electrolytes and extra salt. He is diabetic and suffers frequent urination. Is it due to diabetes or he is developing a kidney disease?
Yeah, one method to figure out whether it's kidney disease or not is to check a serum creatinine urine estimation. The reason why he is hypotensive in a diabetic is probably he's got something called autonomic neuropathy, where diabetes can affect the nerves as well, and it can affect the nerves of the blood vessels, and the blood vessels get dilated, and then the blood pressure drops. So in this situation, if the blood pressure is low and it is responding to salt, then yes, he should take more salt. And to see whether he's got kidney disease or not, simple tests: do a serum creatinine, do serum electrolytes, do a complete urine examination, and you will find out whether he has kidney disease or not. One other method is about this hypotension. Check the blood pressure in the lying down posture as well. That's one way to differentiate between autonomic low blood pressure. So in the standing posture, the BP will be low. In the lying down, it might be high. That will give you a diagnosis of autonomic neuropathy, and you have to treat the diabetes for that. And there are some medications to increase your blood pressure as well.
True. Mr. Harshad is asking, my mother is diabetic and takes metformin twice a day. She frequently have baggy eyes and swelling of both the feet, which pits on pressure. What do you, as a doctor, what do you suggest? Whom should she consult? Which type of physician? Endocrinologist or a cardiologist?
She should she should see a nephrologist, because swelling of the feet and puffiness of the face is probably a kidney issue. But there are 7 or 8 different causes of swelling of the feet, and I'll quickly run through them. It could be low hemoglobin, it could be heart disease, it could be thyroid problem, it could be liver disease, it could be kidney disease where the creatinine has gone up. It could be a different kind of kidney disease where the protein only is less in the urine, what we call nephrotic. Protein is more in the urine, what we call nephrotic syndrome, where the creatinine will be normal, but there'll be a lot of protein in the urine. So 2 types of kidney diseases can cause a swelling: nephrotic syndrome versus established kidney disease itself. And if they can have something called DVTs or clots in the veins, in the legs, that can cause swelling. So these are the 7 or 8 causes of swelling. So she should see a nephrologist and he can do the investigation. There are simple basic investigations for this. Can do all these investigations and she can figure out what the cause of the swelling is. And also one question to Harshal: how much water does she drink? For example, if she's drinking 4 or 5 liters of water and taking a lot of salt, that could also cause the swelling. So make sure the water intake and the salt intake is to the minimal, and get her to see a nephrologist who will figure out what the problem is.
True. I'm receiving many questions in the WhatsApp also. There is one question from a gentleman. My father is diabetic and also takes medicine for blood pressure. Now he is worried. Does it increase the risk of kidney disease?
Diabetes and blood pressure, which are uncontrolled, will increase the risk of kidney disease. If you can control the blood pressure and blood sugar, it will minimize significantly the risk of kidney disease. And ideally, if you have diabetes and you're worried about kidney disease, the two best medicines for blood pressure are either something called ACE inhibitor or ARB. So the names are enalapril, lisinopril, captopril, and telmisartan. These are the drugs for blood pressure. And for blood sugar control, dapagliflozin currently is the best treatment of choice for diabetic kidney disease. So controlling blood sugar and blood pressure will definitely minimize his risk of getting kidney disease, and preferably use one or two of these medications to control the sugars and the blood pressure.
Yeah. Mr. George has asked, he has WhatsApp. He is 32 years. His father is type 1 diabetic. He is on insulin. And George himself is becoming a pre-diabetic. And he has recently found there is, doctor has said there is a protein in the urine. And is it related to kidney disease, or he should be worried about?
No, definitely, George, your protein in the urine is related to kidney disease. You need to do this microalbumin test and figure out exactly how much protein is going. Like I said, if it is 30 to 300 milligram per day, you have hope of complete reversal of diabetic kidney disease, and your protein levels can come down to 0 with treatment. If it is more than 300 per in that microalbumin test or the urine albumin test, you will require further treatment, but you can definitely slow down the progression. So the crucial thing for you is to immediately establish how much protein is going in the urine. For that, you have to do this urine microalbumin test and also do a serum creatinine. So if the urine microalbumin is 30 to 300, creatinine is normal, then you've got early stage diabetic kidney disease. It can be completely reversed. If it is more than 300 or the creatinine is more, it cannot be reversed, but it can be slowed down, and a lot of damage limitation can be done. And there is still a lot of hope for you because you're still 32. You must be aggressive with treatment right now before it gets too late. So meet your local physician and ask for these two tests, a serum creatinine and a urine microalbumin.
Okay, perfect answer. Doc, other questions or minor questions are there which you have already answered in a presentation, but I will take one question as a general person. As diabetic patient, what should be the patient looking for some signs and symptoms so that they can avoid the kidney disease? As short as straight line you can answer.
Swelling of the face, swelling of the feet, decreased urine output or increased urine output, breathing difficulty, loss of appetite, tingling and numbness of the legs, and reduced sleep. These are the features of diabetic kidney disease, the earlier signs. If you want the single most important sign, it is swelling of the face or the feet. If that is there, then you have suspicion of diabetic kidney disease. That's the most important sign.
I think you have given a benchmark to everyone, all the diabetic patients. They must follow up and look for these symptoms. If they develop, immediately they have to rush to their treating physician or a nephrologist for further investigation. I think all the questions are being covered. Thank you so much. Professor, you can take it.
Thank you.
Dr. Ravi, one quick question from my side, sir.
Yes, Professor.
Correlation between fluid intake and kidney health. If you can give us your thoughts on that.
Yes. So the simple method to decide how much fluid you are allowed to take is look at your feet. If your feet are swollen, you should restrict fluid. If your feet are not swollen, you can target 2.5 to 3 liters of fluid per day. So the recommended fluid intake for any human being who does not have swelling in the feet is 2 to 3 liters a day for a normal activity person. If you are very active and you sweat a lot, or you work out in the sun a lot, or you're moving around in the sun a lot, then maybe you can increase it to 4 liters. but definitely not more than that. There's this misconception that people should drink liters and liters and liters of water to maintain kidney health, and people end up drinking 7 or 8 liters of water. No, that's wrong, because the two problems here is, one is you're overloading the kidneys. You drink more water, it's got to come out somewhere. The only way it can come out is through the kidney, and the kidney is working overtime to excrete those 7 liters of water that you're drinking. The second problem is you can dilute the sodium in your blood and cause something called hyponatremia, which is life-threatening. It's life-threatening. So if you drink too much water, your sodium levels will drop, and you can have coma, you can have seizures, unconsciousness, and even death. So water intake should be restricted or should be maintained at 2 to 3 liters per day if you don't have swelling. If you have swelling, restrict it till the swelling goes. So first, if you have swelling, come down to 1.5 liters. Still there's swelling, come down to 1 liter. And if you still have swelling, then you need to take medications to get rid of the water. So your decision on water intake is based on your activity and on whether you have swelling in your feet or not.
Thanks so much, Dr. Ravi. Friends, it is my pleasant duty to thank the people involved in this, in bringing about this webinar, and in making it as successful as it was. First of all, I would like to thank Dr. Ravi, my dear friend. Thank you so much, Dr. Ravi. It was very kind of you to accept our invitation, at my very first call. You were so kind, and your profile made me realize with some embarrassment that I really should not have imposed on you with your great success in your work. Thank you so much for this presentation. It was, as Dr. Wilku said, it was simple enough for a child to understand, and yet so profoundly important. And that is a famous theory. If you can explain a complicated subject in simple terms, you are an expert. And thank you so much for that, Dr. Ravi. Thank you so much. I'd like to thank our audience who has been with us over the last several months throughout this diabetes challenge. And I'd like you to know that in due course of time, we will have our weight loss challenge, and thereafter we will have our fitness challenge, and thereafter we will have our cardiac challenge. Now, thousands and thousands of our community participate in these things, and I'm grateful for your presence. This webinar and none of our webinars would have been possible without the help of Dr. Wilku. Dr. Wilku not only asks the questions, the sometimes uncomfortable questions, but he also sources the speakers by selecting individuals and talking to medical professionals, selecting the topics, and so on and so forth. Dr. Wilku, we are so grateful. And of course, Dr. Wilku's support system, and that includes the entire RAC hospital. It includes the wellness department. It includes our IT support. It includes the entire team over here. Now, we do have a presentation again next week, and that will be an interesting subject, and that subject would be on alternative medicines. These are on alternative medicines. Now, we do know that there is great value, and that giant strides have been made in diabetes through our allopathic tradition, but we do have a few speakers who will talk to us now on the alternative aspects, which means the medications that are beneficial to diabetics from the alternative sources of homeopathy and so on. With that, ladies and gentlemen, thank you so much for participating in this webinar. Dr. Ravi, grateful to you, sir. My colleagues, thank you so much and good day.
Thank you, Professor. Thank you, Dr. Ravi. Thank you, everyone.